Hi, everyone, and welcome to our React 19's virtual rounds call. It is October 18th, and I apologize for being a little bit late. My computer died, so gotta love Apple. Everything was fine, and then all of a sudden it wasn't. So welcome. I want to go ahead and just quickly do what I always do and give you our mission statement, and then I'm going to let Dr. Harch get started. So React 19 is a science-based nonprofit offering financial, physical, and emotional support for those suffering from long-term COVID-19 vaccine adverse events globally. Our mission is to bring healing to moms, dads, friends, and loved ones who are facing the life-altering side effects from their COVID-19 vaccine. We build bridges between patients, research institutions, in order to develop a better understanding of our vaccine complications. So our speaker tonight, as I mentioned before, is Dr. Paul Harch. Dr. Paul Harch was an emergency medicine and hyperbaric medicine clinician. Dr. Harch is a clinical professor of medicine, section of emergency medicine at LSU, Louisiana State University, School of Medicine in New Orleans, and former director of the University Medical Center Hyperbaric Medicine Department and LSU Hyperbaric Medicine Fellowship. In 1989, when some people on this call may not have been born, or at least not out of school, not me, he adapted concepts of conventional hyperbaric oxygen therapy, HBOT, to treat and conduct research on patients with wounds in the central nervous system. That initiative resulted in a private practice with one of the world's largest and most diverse case experiences in neurological hyperbaric medicine. In March of 2020, Dr. Harch proposed the use of HBOT to treat COVID-19 pneumonia based on similar and successful use in 1918 for patients dying of Spanish flu. Dr. Harch has now successfully treated patients with long COVID and COVID vaccine injuries. So Dr. Harch, he spoke at the FLCCC conference this past weekend. It was awesome, although it was brief. And we're going to give him a little bit more time tonight. So Dr. Harch, are you on here still?
I'm on.
Okay, awesome. So I'm going to hand the floor to you. And if everyone has not already done so, please make sure that your mic is muted. And Dr. Harch, take it away.
All right. Well, thank you very much. Let's get the screen up here and slides and everything. First of all, thank you for the invitation. I appreciate it, and I'm honored to be here, to be able to talk about this. Unfortunately for you who were at the conference, for the people who were there, this might bore you a little bit because it's going to be very similar, but just at a slower pace. We were pretty time constrained in 30 minutes everybody had to pile in all the information on the given subject matter, and so it's a little compressed. But there are a few other things that I put in here, and we have a little more time to talk about. The other main point here that I want to make at the start is that when I was invited to give this talk, I pointed out to Angel that there is let's say it this way, there is no published experience on hyperbaric oxygen therapy in COVID-19 vaccine injury. I have one case that I've treated, and beyond that, I don't know how many other hyperbaric centers or doctors out there have delivered this therapy to people with vaccine injury. So the argument I'm going to make to at least try this is based on the treatment of the pathophysiology and the collateral argument or parallel argument of how it's working in acute COVID and long hauler syndrome. So there's the title of it, hyperbaric oxygen with COVID-19, acute infection, long hauler syndrome, and vaccine injury. As it turns out, they had asked us, the conference on the weekend was on the treatment, evaluation, treatment, essentially of spike protein disease. And every time we walked through the conference lobby there, and I thought of the people who just are coming through, who are at that resort. You look at spike protein disease, you have absolutely no idea, most of the public, what that's even about. And I think there was kind of a tendency to have to conceal what we were doing and so on. And we're in this very information suppressive environment where you almost can't talk about it. And so I changed the title of it to this, that I'm talking about COVID-19 and vaccine injury, long hauler syndrome, et cetera. And after changing the title of it, I went back to my hotel room on Saturday, and lo and behold, here's this email. The YouTube totalitarian police censored me and took down my lecture, which is essentially the lecture you're about to see, telling me that my content posed a serious risk of egregious harm by spreading medical misinformation about vaccines that have been deemed approved and confirmed to be safe and effective by local authorities. I don't know which ones those are, and the World Health Organization. So I should give you a forewarning here that I'm about to give you dangerous, egregious, potentially harmful information. So beware. All right. The discussion of this, we've got to start really from square one, and everybody needs to understand what this therapy is, because the answer to this question has—
Excuse me 1 second, Dr. Harch. I'm very sorry to interrupt, but we don't see your slides. We see your menu. We see all kinds of stuff there.
I am screen sharing. It says you are
files
screen sharing. Huh?
So we see your files, but we don't see the PowerPoint hasn't been started.
Wow.
Yeah, I think once you screen share, you have to choose the actual if you had this up first, when you click on your link, Dr. Harch, it won't pull up what you clicked on. You have to go back and share what your slide presentations. You'll oftentimes have a menu that identifies what options you have to share. So if you click the screen share again, that
Hang
should.
on. So you are screen sharing. So stop share.
Stop sharing and then go back to screen share, and it's going to give you 2 options. Choose the other one.
Share sound, optimized for video clip, advanced files. What?
I think it's desktop. So if you pull up your desktop.
Huh, I've never had this problem before. So where are the other choices? What choices am I supposed to have?
Usually it gives you choices of the different things that are on your desktop. Like right now, I just clicked on share screen. It gave me whiteboard, a bunch of Dr. McCullough's things.
There you are.
There you go. You got it.
Well, son of a gun.
Okay, take 2.
All right, gosh. Well, you
can edit this out.
Yeah, you at least heard it. So there's the little YouTube police statement. And so again, starting from the beginning, asking what this therapy is, it's the answer essentially has been unanswered for 347 years until 2008. And essentially what we are doing, this drug, we have a 2-component drug, hyperbaric oxygen, and it's increased pressure and increased pressure of oxygen. And what we're doing is not treating diseases per se, we're treating disease pathophysiology. So the underlying processes that cause diseases. And what we're doing is taking advantage of all living organisms' sensitivity to pressure and oxygen. So we all understand that living organisms are sensitive to oxygen. Of course, without it, there's no life. But what about pressure? It's something we live with. People don't think about it though, but pressure is an actual, it's called a thermodynamic intensity parameter, very similar to temperature. And atmospheric pressure is the weight of air from the elevation of wherever you're standing, let's take it sea level, to the boundary of the Earth's atmosphere, which is 62 miles up. And hydrostatic pressure is the weight of water, seawater, fresh water, whatever you're in, to whatever depth you're at below the surface. So if we look at the atmosphere and the mesosphere up to about 100,000 kilometers, the weight of our air all the way up to that level where it becomes essentially a vacuum in space is 14.7 pounds per square inch is the weight of air on Earth at sea level. And that equivalent amount of weight, 100,000 kilometers of air, you can duplicate going underwater 33 feet. So the weight of water, 33 feet, is equal to 100,000 kilometers of air straight up. And it turns out living organisms are adapted to live at different pressures. We see this with all sorts of species of birds. We see it with crops, and livestock seem to grow or I should say thrive at different levels. And we see it in the ocean under greater pressure. So sea flora and fauna, there are different species that live at different levels and adapted to that pressure. And this, you can see that with really all sea life. But to get the pressure effects that we get with hyperbaric oxygen, or really the atmospheric pressure changes, which on a daily basis, or I should say over a month's time, weather changes, our atmospheric pressure changes about 10%. With hurricanes, you get more extreme, drops in pressure. But to get the effects of pressure, you have to essentially you can have it focally addressed, but it's then just an effect on the site that's exposed superficially. Otherwise, you have to totally enclose your body in it. And that's what we do in a hyperbaric chamber. And it turns out, and this has been shown with tissue experiments with cells and so on, that the effects of pressure begin within seconds of closing that door and turning on the pressure in the chamber. Well, this has never really been appreciated in clinical medicine. And I'm talking never up through roughly 2011. In 2011, I applied to the FDA for an investigational new drug exemption for a study we were doing on traumatic brain injury, and you can find it on the internet. It's a free download. And I was asking for what's called a special protocol assessment from the FDA, which means that they review your protocol. If they agree to it and sanction it, it means that your results can be used to get a new FDA clearance or indication for whatever you're trying to experiment on or prove. In this case, hyperbaric oxygen for traumatic brain injury. Well, for the first time in 60 years in American medicine, hyperbaric oxygen therapy was moved from the devices and radiologic section of the FDA to the drug side under medical gases. Oxygen is a medical prescription gas. And that section, the doctors who reviewed it said, look, this is the first time we're looking at hyperbaric oxygen. We're having a fresh look. We really don't know anything about it. But, doctor, you're asking for a clearance to look at one dose of your drug. And your drug has two things. You're increasing the pressure and you're increasing the oxygen. We don't know if one, both, neither, either work. You got to prove that with a lot of experiments on different pressures and different oxygen levels, i.e. different doses. Now, dose finding studies are effectively and essentially what is done with all drugs that are that have experimental trials and seek FDA approval. And that's where you get the recommendations for dosing range. But nobody has ever thought of that in that way in hyperbaric medicine. And I thought the FDA was just nuts and just being obstructive and difficult. So I went to the library, and here is the article with roughly 50 years summarized of elegant physiology showing that all living organisms and cells are sensitive to changes in pressure. And if you look at the pressure limit that they were looking at, it was from as little as less than a centimeter of water pressure to 1.3 atmospheres, which is curiously the pressure limit of the Gamow bag, which are the portable chambers that are sold in the United States and internationally. And if you summarize all of those articles in that review article, and this is an abstraction, it's published in a letter to the editor I put regarding the Department of Defense traumatic brain injury hyperbaric studies that were so errantly constructed. Look at these pressures, 1.21 to 1.26 atmospheres. That's roughly, 18, 20 feet of seawater to 25 feet of seawater. And 1.0015, again, less than a centimeter to 1.015. So look at these for 15 minutes or longer and causing a whole variety of effects. Elaboration of vasoactive substances, growth factors, inflammatory mediators, and even causing the cells to proliferate. And that is key. And the exposures, the effect began within 1 minute of exposure to just a little bit of pressure. So how does that translate to what we're doing clinically? If you look at hyperbaric medicine in the United States, we have been restricted, if you will, for a number of reasons, to a list of 15 reimbursable diagnoses. That's not lightning. We got a flicker in the light behind me here. But here's the list. And this has been the Achilles heel of hyperbaric medicine. Air or gas embolism, carbon monoxide poisoning, crush injury, diver's disease, decompression sickness, problem wounds like diabetic foot wounds, exceptional blood loss, anemia, in other words, massive bleeding, radiation tissue damage. And I want you to look at those. And when new physicians are presented with this list, they kind of give you this quizzical look and, look at you like, what? Try to draw a connection between them. And you really can't. It turns out, though, they are all, if you look at the right-hand column, wounding conditions, either acute, subacute, or chronic. And same with the rest of the skin grafts and flaps that are compromised, thermal burns, stroke of the eye, which is central retinal artery occlusion, main artery that goes to the retina, idiopathic sudden sensory hearing loss, which is sudden loss of hearing. And then the last four are wound infection conditions. So everybody's probably heard of gas gangrene, common in war wounds, the flesh-eating bacteria, which was a scare at one point, but has been present forever, chronic bone infections, and brain abscesses. Again, they're all wounding conditions. And what in fact ties them together, I'm going to explain in just a minute. If we go to other countries, though, this list of diseases is much larger. And in a critical article that was written in 1987, that Gabin Robin article, they listed 132 diseases that people had made claims that hyperbaric oxygen could impact. And of course, the hyperbaric medicine field, unable to explain that, it was looked upon as a fraudulent therapy and so on. It got a bad name. But if you look at them in detail, they're all wounding and inflammatory conditions. And that inflammatory statement and immune dysregulation is what I want you to focus on for the rest of what I'm going to talk about here. It turns out I've treated about 100 conditions, most of which are different neurological conditions and all the standard ones that we treat. But what connects all of these is the underlying disease processes. So what we're doing with hyperbaric oxygen, we're treating the underlying pathophysiology in wounding conditions. And the conclusion is that hyperbaric oxygen is a treatment for wounds in any location and any duration in the body. And when you treat a wound and heal it, how do you heal it? You've got to stimulate growth of new tissue, inhibit inflammation, and essentially repair the wound. So if the daily input over here on the left is a hyperbaric exposure, meaning to increased oxygen, increased pressure, and the output is growth of new tissue, repair, and so on, you have to go through the nucleus. You have to stimulate the cells to divide and multiply. That involves gene signaling. And this is what has finally been appreciated now, beginning in 2008. This is just a cross-section of one of our chromosomes and the DNA. You can see the double helix here in green. It turns out our DNA is coiled in rings like this, and then an even super ring. And in the middle of the coil of DNA are proteins. They're called histone proteins. And they have arms that stick out here. You can see the different colors that are, quote, reactive moieties, like acetyl groups and methyl groups and so on. And they are very reactive. And in fact, those moieties are affected by stress, lifestyle habits, sleep deprivation, alcohol, tobacco, drugs, pesticides, chemicals, literally everything in our environment. And what happens is they react with these reactive moieties. And when it does, it changes the electric charge and conformation of these proteins. And when that happens, these proteins that are sitting on the initiator segment of genes either gets locked down or opened up. Or I should say, it remains open and locked open, or it gets closed down. And the gene either then gets read or is not read. And so what we have here in 2008 was an experiment where a doctor in Massachusetts, Dr. Cassandra Grodman, took human endothelial scales from skin biopsy. So, you go have a mole biopsy, they cut a piece of tissue out. They took the normal blood vessels out of that and isolated the cells that line the tiniest blood vessels in our body, and they're everywhere in our body. All the tiny blood vessels are lined by what are called endothelial cells. They, in fact, are the most reactive cells in our body. It's where disease really is manifest, is in the microcirculation. But they put them in a petri dish, gave them a single hyperbaric treatment, and that dose up there is the standard dose that's delivered, but a little bit shorter. Normally, they're 90 to 120 minutes for most wound healing conditions, so diabetic foot wounds, radiation injury, et cetera. And what they did after that exposure for 1 hour, they measured all of the gene output for 24 hours continuously. At the end of 24 hours, 8,101 of our 19,000 protein coding genes were either turned on or turned off by a simple change in pressure and oxygen. And the largest groups of genes that were turned on were the anti-inflammatory genes and the growth and repair hormone genes. Largest ones, clusters turned off, were the pro-inflammatory genes, ones causing inflammation, and the cell death genes. If they gave another treatment, by 48 hours, more genes got expressed or suppressed, and the cells started rounding up to form microvessels. Now, these are effects in just normal, non-diseased human tissue, which gives some idea about what this may potentially be doing in aging and people who do this later in life for, quote, anti-aging effects. Well, so what we're doing with hyperbaric oxygen, which has been unbeknownst to this entire field for 360 years, or 347 up to that time, is that we're modulating gene expression and suppression. What we have here is an epigenetic therapy. And now we go back to these lists and these inflammatory conditions, and you could really ask the question, there may be more than what are listed here that could be sensitive to hyperbaric oxygen. Well, again, we're treating the underlying disease processes, and that's how you can treat so many of these different conditions, because they're common to so many diseases. Well, what is the common pathophysiology in wounding? It's ischemia, lack of blood flow, hypoxia, lack of oxygen, and inflammation, which results from trauma and the ischemia and the hypoxia. But inflammation is a part of it. So we have evidence that you can affect inflammatory processes in just normal tissue. But in addition, there are now multiple review articles. Here are 5 of them and 2 more showing that hyperbaric oxygen suppresses inflammation. This one, which is a review in inflammatory bowel disease, showing that it suppresses inflammatory cytokines. Remember what's going on in COVID, cytokine storm. So this has direct application. Here is a review in wound and trauma conditions. Again, cytokine downregulation and suppression of pro-inflammatory cytokines. So we have an effect on inflammatory tissue and disease processes. Well, what is probably one of the most inflammatory conditions in all of medicine? It's the adult respiratory distress syndrome. Intense inflammatory reaction in the lungs. And it's caused by many different things: trauma, infection, hypoxia, sepsis, etc. It turns out we've got literature, published literature, on the effects of hyperbaric oxygen on ARDS. The first one there is RCT, is a randomized controlled trial. And this was in severely burned patients who were given hyperbaric oxygen versus a control group, got standard care. And what they looked at was the subset of patients. I mean, they looked at the overall effect on reducing burns, surgeries, all of that, complications. But they also looked at a subset of the patients who had ARDS and were on a ventilator. It turns out 10 of them were hyperbaric patients, 5 of the control group. And what they found delivering hyperbaric oxygen to this one group was that there was no deleterious effect of the HBOT on the ARDS. But what they found was an 80% reduction in time spent on the ventilator, 5.3 days for the hyperbaric group, 26 days for the control group. Statistically significant, very significant. There was then a prospective case series that looked at mechanical ventilation outcomes in all of their hyperbaric patients of all different causes that were on ventilators. And 35 of them had ARDS. When they looked at the overall mortality, again, people thought at the time that hyperbaric oxygen could worsen and cause a deterioration in ARDS, because one of the primary lungs that manifests oxygen toxicity is the lungs. But they found the opposite. In fact, their overall mortality was down at the low end of the historical mortality range for ARDS of all causes. And the final one was this retrospective controlled series of blunt thoracic trauma patients. So this was a group of patients it was collected in the late 90s and published in 2003, who had undergone severe blunt thoracic trauma. 45 of them, 26 of them developed ARDS within 72 hours of the trauma. And 8 of them, they gave hyperbaric oxygen because they had chambers by that time, but the previous 18 got standard of care. And look at the dose of this, because this is going to have some meaning here in a little bit. 1.6 atmospheres to 2 atmospheres. So remember, 2 atmospheres is 33 feet of seawater below, or 33 feet of seawater pressure if you were scuba diving. And the equivalent, usually treating in hyperbaric chambers for chronic wounds and emergent conditions, is 2.4 to 2.8 atmospheres. But what they did was very short treatments, 40 to 60 minutes, and on average, they had about 10 treatments. Mortality in the 10 hyperbaric patients was 0, with 77% in the ones that, or excuse me, in the 8 hyperbaric patients, and 77% in the 18 that got standard supportive care. All right, so how does all of this apply to COVID? Well, what's the pathology? Well, in acute COVID, it is inflammation and exudate in the lungs, systemic inflammation, and thrombogenesis, which is the result of inflammation primarily directed at endothelial injury. And of course, the oxygen debt that the patients accumulate during the period that they're hypoxic. And there's now some elegant research that was published in 2007 by my senior partner on resuscitation, showing that he resuscitated pigs that had had cardiac arrest for 25 minutes. And this was based on the resuscitation of a diver who drowned in the Mississippi River in 1983 and had cardiac arrest for 25 minutes. We put him in a chamber, took him to 6 atmospheres of pure oxygen. He woke up, complete survival and recovery, IQ afterward 123, and went on to live a happy, longer life. The point is, what he was able to show is that what is normally considered a fatal oxygen debt can be reversed with a single hyperbaric treatment. So oxygen debt is something that also accumulates and contributes to the mortality in COVID patients. In long hauler syndrome, what's the dominant pathophysiology? It's inflammation and immune dysregulation. And I use those two interchangeably. And in COVID vaccine injury, the dominant pathology and pathophysiology is inflammation and immune system dysregulation. So if we take a look at the novel coronavirus, just a couple comments about it. I don't know why this thing's automatically advancing. It's an RNA virus, primarily in humans, similar to the previous SARS and MERS virus, and interestingly, very, very similar to Spanish flu. It's highly infectious, and the comorbidities seem to be important because dominantly they have effects on our immune system. And the number one, which has just not been talked about, and it should be, is obesity. And that's the driver behind diabetes, which is one of the big comorbidities, and hypertension, which is another comorbidity. Hyperlipidemia, chronic kidney disease also, and of course, elderly who are immunosuppressed. Natural history, 5 to 6 day incubation, the infectious period, and symptom essentially deterioration over 48 hours or so. Upper respiratory symptoms mainly, but there's kind of a wide variation in this. About 40% are mild disease, 40% moderate, and the rest severe. ARDS in about 3 to 5%. Overall mortality somewhere maybe in the 2% or 1% range. And the pathology, inflammatory, and exudates in the lungs, systemic inflammation, thrombogenesis. I don't know why this thing's automatically advancing. And the thrombogenesis. Clinical problems, of course, the pneumonitis, the progressive hypoxemia, cumulative oxygen death. And so it's infection, inflammation, and hypoxia. And here's just a picture of normal lung on the left and on the right, showing all of the inflammatory exudate, the interstitium, which is clogged with inflammatory cells, exudate in the alveoli, and essentially a messy lung that is pretty white on chest x-ray. Okay, so how'd this all come about with hyperbaric oxygen? In January of 2020, my wife, who's a nurse, has multiple sclerosis, and you would not be able to tell it. She's had 450 hyperbaric treatments and has had no deterioration in 22 years. Started pestering me and asking, how about hyperbaric oxygen in COVID? And I said, well, that's been done before, really. History bears remembering. And I took her back to the Spanish flu. The introduction of hyperbaric oxygen therapy in the United States was in 1918 during the Spanish flu pandemic. And Dr. Orville Cunningham, who was in Kansas City, anesthesiologist, was vacationing in Colorado. And he got to contemplating why, or thinking about why the mortality for Spanish flu patients was so much higher in the Rockies than it was at sea level. And he said it has to be due to the lower pressure, higher altitude, and the attendant lower oxygen. And he thought, what would happen if we gave more pressure and more oxygen? Raced back to Kansas City and built this old hyperbaric chamber from spare parts, old boiler. And the day he was operational and ready to start his animal experiments, because, at the university, you got to do animal experiments before you do humans, someone brought him a dying Spanish flu patient, young man. And it's described in this book and in this journal article by one of his residents years later in 1964. And they talked about how one patient after another, agonal breathing, cyanotic, gray, and really near death. Once they put them in the chamber and pressurized them, they pinked up, started coming back to life, breathing became less labored. And the curious thing about it was they didn't have bulk oxygen in those days. So this was just with compressed air. Compressed air was what the entire field of hyperbaric medicine was built on from 1662 up to about 1955. And so here he was salvaging these patients, and it was so successful. He went on to treat all sorts of other conditions, generally in this range. You can see it up there in yellow, 1.34 to 2.36 atmospheres. So again, that's somewhere in the range of 12 feet of seawater to about 2.36 is somewhere around 38, or so feet of seawater, 39 feet. And he treated a variety of chronic illnesses, including lung diseases, emphysema, bronchial asthma, other lung diseases. There's now some duplication of this in some published experience with patients that they took to the Dead Sea, which is increased atmospheric pressure. But a comment of his was a peculiar action of this treatment is the regeneration of nerve fibers. And I would suggest to you that is part of what may be going on in treating COVID long haulers and the brain manifestations of vaccine injury and such. Well, his success with all of these Spanish flu patients, he was literally overrun, led to the building of this 108-foot chamber here on the left-hand side. And then eventually this 5-story steel ball hyperbaric hospital, which went up in Cleveland, Ohio. So there's a lot of precedence for this. And if we look at Dr. Cunningham's dose for COVID, 1.68 atmospheres of air. Now, I want to take you back to what the ARDS dose was in those studies I showed you. In the one study, that last one with blunt thoracic trauma, it was right in this range, 1.6 to 2 atmospheres for short periods of time. Well, if we look at 1.68 atmospheres of air, that's only 0.35 atmospheres of oxygen. That's the amount of oxygen you get putting on, let's say 5 liters of nasal cannula oxygen, or 5 or more liters by a vented face mask. It's not a lot of oxygen. And Dr. Cunningham, it was 1 hour treatments once a day for about 5 days. And he got them over the critical period and salvaged them. Well, if you go back and look at the mortality from Spanish flu, and here it is in October of 2018, these are national statistics. You see mortality jumped to a huge number, 300,000, that number there, actually it was 180,000. If you look at the cause of death, about, maybe 40% of them were bacterial pneumonias. The rest were flu pneumonia. And if we look at Spanish flu and COVID, yeah, they're both RNA respiratory viruses. And the mortality was primarily from what was happening in the lungs. In the ARDS and bacterial pneumonia for Spanish flu, but ARDS in COVID, not necessarily bacterial pneumonia. If we looked at the ARDS and Spanish flu, it had 100% mortality. In COVID, about a 53% one. But we know that hyperbaric oxygen does not have primary effects on aerobic bacteria unless you couple it with antibiotics. Well, Fleming didn't discover antibiotics until 10 years after the Spanish flu pandemic, and it wasn't available to people until the end of World War II. So what Cunningham had to be treating was not the bacterial pneumonia patients, but the Spanish flu ARDS, which leads us to COVID-19. So I put this announcement on the internet on March 10th, just encouraging doctors, hey, we may have a treatment for these severe COVID patients. Take a look at it. We should do hyperbaric oxygen. Turns out we got the governor of Louisiana pledged $1 million to us in research money to do the study. We had it all done. We had the IRB approval. And before they signed the document, IRB chairman called me and said, does the hospital have approval of it yet? And we had to wait. I said, no, we didn't have it yet. Turns out the hospital blocked this and refused to let us do it. So we never got to do this acute study. But what happened was the day after we put this announcement up, my wife found an article that had been released on the internet by a Chinese chamber manufacturer. It was a public relations piece. And what it was a report of 5 critically ill COVID patients in Wuhan, China, that some doctors put in a hyperbaric chamber there and treated. And they had written this manuscript, gave it to a colleague to kind of review, and he took it, stripped all the authors' names off, and put it out on the internet, thinking that this thing just needs to be out there. Well, they had already submitted it to the Lancet and New England Journal, and it got rejected. And so I called up the chamber manufacturer in China, whom I knew, and I got an interview with this treating doctor in hyperbaric unit in Wuhan, and had a long conversation with her, Dr. Zhaoling Zhang. And in the conversation, she told me they had now treated 35 patients. Well, only 6 of them were the very ill ones. One was on a ventilator. They ended up pressurized, if you will, by the hospital administration to treat 29 much less ill COVID patients, because these other patients saw how rapidly the COVID patients got better in the hyperbaric unit, and they demanded it from the hospital administration. Now you can think of this is in a Chinese military hospital. You don't demand anything, but the administration caved in and they treated 35 of them. And after that, they had passed the peak of the pandemic. They had no more patients that they were treating with hyperbaric oxygen. Well, I started to work with them to get this translated into good English, and I talked to her and I said, well, are you aware of what happened in the United States with Spanish flu? I said, they treated the patients with pressure, just like you did, but there was no added oxygen, meaning no supplemental. It was just pressurized oxygen in the air. And what ensued was this frenzied conversation with the translator and her. And after about 2 minutes, I finally said to the translator, what is going on here? She's just so excited. He said, she wants to let you know that she has been trying to tell her colleagues she thinks that this is more the effective pressure than the oxygen, because they had no attendance in the chambers with the patients. And when they would go in there, some of them, the masks came off. And what they found was their pulse oximetry didn't drop. Now in the chamber, when you're at 1.6 to 2 atmospheres, the amount of oxygen you're getting is the amount you're getting with just some nasal cannula oxygen. These patients were already on 100% O2 by face mask. So they were getting more oxygen outside the chamber than they were in the chamber on pressurized air. And yet they were calm, they were getting the benefit. And so we tried interjecting and putting in the manuscript that the effective pressure was there. And in the end, the one doctor who was the bilingual one writing the paper disagreed, and he turned around and just submitted it in Chinese. And so it unfortunately got published in some Chinese medical journals, military journal. Well, what ended up happening, I took the one piece of data that had been released on the internet and I published it in this English language journal. And what this shows is these 5 patients. The bottom turquoise line on the graph is their pulse oximetry each day before they went in the chamber, right before they compressed it. So they took a pulse oximetry reading right outside the chamber, and you could see where they are. Now they're on oxygen, maximum supplemental oxygen. Now the Chinese, they actually weren't using a non-rebreather mask. They had this funny, it was a tight-fitting mask, and I don't know that they were getting 100% oxygen, but it was their maximum delivery of surface oxygen. And you can see the average pulse oximetry of these patients was in the 74% range. After a single hyperbaric treatment, we'll see up on the graph, it was up in the 90%. And then they took them out of the chamber, it drifted down. But over the course of the day, usually by the evening, it had come up. And by the following morning, that is the second point on the turquoise graph there, where you see they're now up above 82%. After coming out of that second treatment, again, the value is up on the magenta line there. And gradually what happened is there was more than just a transient effect of what happened in the chamber. There was something the hyperbaric therapy was doing to change the lung pathophysiology. And on a daily basis, they gradually improved to finally they were at that threshold of 90% pulse oximetry, generally in medicine considered the lowest threshold for acceptable systemic oxygenation, and they stopped treatment. So they delivered on average 3 to 8 treatments, but they used pure oxygen, and it was 1.6 atmospheres, not very deep. Remember, Cunningham, 1.68 of air. The data suggests that the more dominant component here may be the pressure, which has just been unappreciated in this field for all these years. Well, since that time, there have now been a whole series of published studies on hyperbaric oxygen in COVID, and I'll bet you haven't seen one of these. It's, medical information, boy, getting disseminated for this subject is very difficult, but these are all published in journals, and I've highlighted the pressure ranges. So you look at this, it's anywhere from about 1.4 to a little over 2 atmospheres. And I want to look at the very bottom is the review article that goes through all of them. So you can just pull that one up in the European Journal of Medical Research. But the last one there, number 3, Canelato, is a recent randomized trial in acute COVID, but they weren't real sick patients. And they gave them, on average, 5 hyperbaric treatments. The trial got stopped prematurely at an interim analysis because there was such a statistically significant difference between the 2 groups. The hyperbaric oxygen group achieved normalization of their oxygen level in 3 days versus 9 days in the control group. But if we sum all of them up, there are varying designs and quality, varying doses of hyperbaric therapy, but consistently the results are positive. We know that hyperbaric oxygen, I should say, it has not been shown that hyperbaric oxygen has any direct antiviral effect. And in general, across the field of virology, it's only been shown for a couple of viruses. One of them is herpes C, I believe it is. So we had to be treating the underlying inflammatory component of acute COVID-19. All right. Well, how about long haulers? You all know what long haulers is because you're in the whole vaccine reaction, field. But this is now well described. Usually the viral shedding, which is the green line, is out of the nasopharynx or done by about 4 weeks. Viral isolation from the respiratory tract, usually done by about a week and a half. But of course, long-term, we have multi-system, or I should say multiple different systems with inflammatory disease. And the spectrum of this is amongst the widest of clinical spectrums in all of medicine for any disease. Figures as high as 80% of people developing one or more of 55 long-term symptoms. Fatigue, most common, but headache, a lot of cognitive symptoms, musculoskeletal, and so on. These figures actually there's some wide variation on them. But if we look, what's been proposed is the underlying cause, virus-specific pathophysiologic changes. Okay, I don't know what that means, but the virus changing the tissue. Well, of course, one of the things that does clearly change, there is a clear-cut immunologic reaction and inflammatory damage that results. That may be what is partly included in virus-specific pathophysiology change, but dominantly the process has been shown to be immunologic and inflammatory. The post-intensive care syndrome, microvascular ischemia, we know thrombogenesis is a part of that, but post-intensive care syndrome just doesn't explain this. And it's very, very long-term duration. Metabolic alterations can be part of the post-intensive care, but really the pathology is not explained by that. So what happened? I in my private practice, where it turns out all of this research has been done on neurological applications of hyperbaric oxygen, I primarily treat neurological disease. And so people started calling me about their residual long hauler COVID cognitive symptoms. And this is one of the very first patients to get treated that I know of. I now have a series of 25 or more. And the vast majority of them, we only have one or two that have not responded to this, but it was a 50-year-old lady, COVID-19, symptomatic for 10 days with kind of the typical spectrum of symptoms there. But from the time of infection, had a lot of cognitive problems, irritability, some vision impairment, chest pain, and ended up with positive COVID antibodies, so proving that she did have COVID, and was left with exertional fatigue as well as chronic fatigue. And by 27 days was not getting any better. Came to see me and wanted to do some imaging and stuff, but this is all out of pocket. So we tried to be as conservative with costs as we could. I gave her and started her treatment at 1.5 atmospheres of oxygen, which is where we had treated so many of the traumatic brain injury patients, where the studies had been done on acute COVID. And I just told her I thought we had a good chance in this range. By 13 treatments, she said, I'm 90% back to normal. I can't believe it. Well, we did 2 more hyperbaric treatments, hoping to get to 100%. She then had some very, very stressful incidents that had occurred with her. She had an exacerbation of her symptoms, which stress will do. That then kind of abated. She got back to where we were. And then she somehow got pressured, coerced into believing that she needed to get a COVID vaccine after she had already had natural immunity. She got the vaccine and had a marked deterioration in all of her symptomatology and deteriorated from this point of improvement after the hyperbaric treatment. She then flew out of town, which made this worse, got us hypoxic, low altitude exposure in the plane. Upon landing and the day afterward, had a re-expression of oral herpes, very, very common reactivation of latent viral disease. We've seen this with Epstein-Barr. It's been seen now with oral herpes and other infections, and frantically started searching around. And in the next 2 weeks, finally found a hyperbaric facility, went in, asked them for treatment at the dose I had given her. She got 2, didn't seem to improve, flew home, and I retreated her and was able to improve her with another 6 treatments. She's been lost to long-term follow-up, but she ended up with a portable chamber and dosing herself further on. She's moved out of the country, so I don't know how she is doing. After that, this was followed by a series of 10 patients that got reported in the literature. And these were all post-COVID patients, symptoms for at least 3 months. Average was over 3 months. And they treated them at a much higher dose. So this is, application of the traditional dosing regimen in hyperbaric oxygen. 2.4 atmospheres for 105 minutes, once a day, 5 days a week. And they did 10 treatments, so a rigid kind of 10 treatment approach. And they measured a fatigue scale, and they did some computer cognitive testing. The statistics they rendered typical ones, but then they did what's called a Bayes factor, which looks at the probability of the alternate hypothesis, meaning the experimental treatment worked, versus the null hypothesis that it didn't. And the higher that number, the more likely that, in fact, it was an effective therapy, or there was positive efficacy. Here are all of the fatigue scale and the cognitive testing, and the before is in light blue, after the 10 treatments, right afterwards in the dark blue. And you can see fatigue goes down, and there was a little bit of improvement in all of these on the scale. Now, who knows if they might have gotten more with a different dose or not, but the outcome was positive. If you look at the p-values, they're positive for most of these. There are 3 of them that aren't. And when they looked at the treatment effect size, and I'm sorry, my old video thing is covering up here, but if you look at the Bayes factor column, you can see that some of these are up in the double digits, and the one that had the highest and most certain result and positive Bayes factor was fatigue improvement. Whoop. Here we go. Well, this was followed by a single case report out of Israel. A 55-year-old man, post-COVID, had the typical symptoms and cognitive problems, and they did a lot of testing on him. Perfusion MRI, diffusion tensor imaging, cognitive testing, cardiopulmonary test, and they did a lot of treatment at a high dose. 60 treatments, 2 atmospheres, 90 minutes with air breaks, once a day, 5 days a week. And these are the before and immediately after perfusion MRI scans. So the color scale on this, blue is decreased blood flow perfusion. And the white matter, by the way, in the brain, which is this central part of each side, the white matter in the brain has blood flow that's about 1/3 of the gray matter. The gray matter are the cells, which are all around the outside, the folds, and down in the deep center, basal ganglia and the 2 thalami, which are continuous with the midbrain and the brainstem. So all of this blue is the white matter, the connecting tracks, which does not denote necessarily injury, but really that's where most of the injury is. What they're showing, if you kind of blur your eyes and just look at the colors, you'll see there's more of the yellows and oranges on this lower row of homologous pictures, which means there's higher perfusion and blood flow. Blood flow is usually coupled to metabolism in chronic brain injury and in normal brain. And here are their statistics. So pre-post change, the percent change, or I should say the percent change statistics are anywhere from no change to, as high as 18.5, but the average is somewhere in around the 7% change in these, which isn't a huge change, but it's all in the right direction. They then reported a randomized trial, same doctors, and what they did was take 37 patients, hyperbaric, 36 in the control group, had been symptomatic for at least 3 months. And again, kind of a high dose, 2 atmospheres, 90 minutes. But they only did 40 treatments for this patient, which I think is probably a better start and more reasonable. And the control group got an air pressurization. They bumped them up to just a little bit of pressure, 1.2 atmospheres for 5 minutes, and then let it drift down to just really having a smidge, to try to fool them into thinking that they got it and have blinding. Well, they only did the blind test for the first treatment. I can just tell you, after doing 40 treatments, you soon know that your ears aren't making the changes that you are with 2 atmospheres. There's also change in temperature with compression and decompression. And so it's unclear if it's truly blinded by the time they're done. But regardless, it's a controlled study and it's good. What they did was computerized testing, all of the brain imaging with the DTI, diffusion tensor imaging, variety of symptom questionnaires, pulmonary function tests, etc. And this first report is on the cognitive testing. So hyperbaric group on the left, control group, this is kind of busy. And this is pre-post p-value for hyperbaric group showing statistically significant improvement in almost everything but motor skills. And for the control group, actually some significant improvement in memory, interestingly, and really nothing else. Almost significant improvement in information processing speed. Kind of makes you wonder if there's something with even that little pressurization to 1.2 atmospheres. Remember the data I showed you earlier with cells, that the pressurization effects begin with just within seconds to minutes. A very slight pressurization. Well, then what they did is they compared the effect size change in each group, and they gave a p-value for that. And I've got to move my little video column over here. And what you can see is they had significance for a few of these, and a few they didn't. But in general, the outcomes were positive. If you look at their values for energy, their sleep outcome instrument. This was, I think, a quality of life instrument, and this one was pain. The control group on top, they're kind of a little bit of change or no change, but a bigger change in the hyperbaric group on these other parameters. So the results of it were significant increases or improvements in cognition, attention, executive function, energy level, sleep, psychiatric symptoms, pain interference, and some improvement in brain MRI perfusion, and some areas in the brain that also showed some changes in the white matter. Okay, last thing, let's talk about vaccine injury. And you people know this way better than I do, but I put this up. This is Pfizer's report. And when you read this, analyses of adverse events during the blinded period included 43,000 participants, 16 years of age. Reactogenicity events among the participants who were not in the reactogenicity subgroup were reported as adverse events, which resulted in imbalances between the BNT162b2 group and the placebo group with respect to adverse events, 30% versus 14, related adverse events, 24 versus 6, and severe 1.2 versus 0.7. New adverse events, I mean, you read this thing and so what the hell happened here? I guess maybe the statistics show there were worse events, but the final conclusion is there's not much. And you look at the graphs here, these are all mild to moderate, and it looks like there's really no difference between the groups. Maybe more of a discrepancy here for fatigue and, you know, headache and so on, but this really got underscored. However, when you look Jessica Rose's report from the vaccine adverse events reporting system, it's a different story. Huge number. And look at the dominant one here, which are immunologic. And of course, the middle age groups are the ones who see the most adverse events. Well, what's the pathology? It's immunologic, immune dysregulation, inflammation. So, you know, how much evidence do we have for hyperbaric oxygen effectiveness in this? I've got my case. I don't know of any other doctors, hyperbaric doctors, that have called me or communicated or I've seen anything on hyperbaric oxygen for other COVID vaccine reaction. However, we're treating the same underlying pathophysiology. We've got evidence for it in normal human disease in terms of regulation of inflammation. We've got it in human disease states with some published experience. It's very, and we've got it in COVID, in long hauler. It very likely is going to have benefit in vaccine injury. But we also have some evidence in some other vaccine injury. And I know this is also very controversial, at least in the general public, but not in a lot of people's eyes and a lot of parents. At least some of the autism cases, I think, are undeniably due to vaccine injury. It could be the adjuvants, it could be just the overall immunologic load, who knows, and with certain of them. But there are published studies now on hyperbaric oxygen treatment of autism. I, in fact, treated the first cases in the United States, actually the second through about the 8th or 10th, and presented these to Dan Burton's hearing. Most of my early cases were birth-injured children who developed autism. But the point is, there's a commonality with it. It's a wounding of the brain. And we have found, and a lot of us have found, that the response rate in these children, about 80% of them with autism will respond to hyperbaric oxygen. Okay. I wanted to put a word in here about dysautonomia because this is a diagnosis and it's kind of pseudo-equivalent POTS that is cropping up in a lot of long haulers and in a lot of patients with vaccine injury. And it's an injury to the autonomic nervous system. The exact site is not clear, but there are either 11 or 13 autonomic nucleus clusters of cells in our brainstem. And that is where the primary autonomic control, that and the hypothalamus, is where it comes from. Well, it turns out there have been a number of studies on human normals and in divers. And what they've shown is that just routine exposure, hyperbaric exposure to pressure and oxygen affects the autonomic nervous system. And its effect is one of increasing parasympathetic output and decreasing sympathetic output. In other words, modulating heart rate variability. And usually what happens in autonomic injury is a an increase in parasympathetic output and a decrease in, well, primarily an increase in parasympathetic, or, excuse me, an increase in sympathetic output. And it's one of the things that we find that's abnormal in divers. And of course, the routine treatment of divers is hyperbaric oxygen. What I've also found in treating a good number of people now with autonomic instability is that they are sensitive to hyperbaric pressurization and oxygen. And in fact, we're able to help this dysautonomia. So if we kind of sum up this, if we look at acute COVID infection, all the data and experience appears to be at least an atmosphere, 1.4 atmospheres for anywhere from 30 to 100 minutes. And that's of pressurization. And I'm saying this with or without supplemental oxygen. Now, the published experience is mostly with oxygen, but it's once a day for 5 treatments or more. For long haulers, there's a broad range. The published doses are up in the 2 to 2.4 atmosphere range for, well, the one report and the randomized trial, 40 treatments, 10 treatments in another, 60 in another. But my experience, and now a number of other physicians, is that the treatment range is all over the place. Some people respond to 1.2 atmospheres of air, 1.3 of air, 1.15 of oxygen, 1.5 of oxygen. And the idea here is, you know, everybody's an individual. And that's been the practice of medicine forever, is trying to deliver treatment that is specific to you, your genetics, your problem, your disease. And what we find is that people, and this is true in other medical conditions, are sensitive to different doses of oxygen and pressure. So for COVID vaccine reaction, I've got one case. I would tell you I have a very strong bias that, based on all of this that I presented you and that we know of, that that people with COVID vaccine reaction are going to react similarly to long hauler and even acute COVID with hyperbaric oxygen therapy. How do you dose it though? And that's kind of the trick and the question. As it turns out, you know, I have been trying to do this for 33 years. And when we started, we indexed it and tried to do this with SPECT brain imaging. And I'll show you that in just a minute. But this is more for people who, let's say you have a post-COVID vaccine reaction that does not affect your brain. And you've got musculoskeletal problems and let's say liver inflammation and some other internal organ. You can't dose this by these methods I'm talking about here with Spectre QEEG. And I'd encourage you in that setting to try at the higher doses. You can start with a low dose initially, but our evidence for inflammation more in solid organs and so on, most of the published experience, like in autoimmune diseases, is at higher pressures. The other thing that can be done, though, with the cognitive symptoms, though, you can use SPECT. What I now use is live QEEG dosing. I'm going to show you this in a second. But really, the best thing, or I should say, the thing that everyone can do is just empiric dosing, meaning practice medicine. And what I'd encourage you to do is to start out low. Try pressurized air and do it for a period of time and see if you get an effect and symptom change. Statistically, you ought to see something early, meaning within probably 15 treatments. But people can be late responders and you may need more. So you end up having to take a guess that they might not be reactive at that dose, and you have to increase the dose or add supplemental pure oxygen, let's say. But again, it's a practice of medicine issue, just like you would dose ivermectin, just like you would dose hydroxychloroquine, like you would dose any of the other supplemental, or I should say, ancillary therapies for acute COVID or long hauler. You have to practice medicine. This is an example of what we did for roughly 12 years to every patient with a neuropathology. And this was one of the autism cases, the very first one that I treated. And on the left-hand side is a brain blood flow scan of this child before his first hyperbaric treatment. And this is on the right-hand side of the image here in the vertical columns. are the transverse slices of the actual brain scan. There's a variability in color there, but the point is the outer surface of the brain, the computer can take and give you a three-dimensional reconstruction. So we're looking right at the patient. Here are the eyes, and this is right behind the forehead, frontal lobes, parietal lobes back on the side, your palm of your hand, which is above your ear, if you put it on the side of your head. Right down here are the temporal lobes, which are sitting kind of right behind or in from your ears on either side. Normally in three-dimensional reconstruction, it looks like a hot dog bun. It's a rounded longitudinal structure. And you can see these are pretty much eaten out. And these are reductions in blood flow of the temporal lobes. As it turns out, 90% of children with autism in brain blood flow studies with SPECT show abnormalities in their temporal lobes. Here he was after one hyperbaric treatment, showing some improvement to the temporal lobe and maybe even some improvement to the inferior frontal lobes, which is the other place of findings. And this, when we saw it, was indicative and predictive. It didn't matter what neuropathology you had, of improvement with repetitive treatment at the dose you gave for that first treatment. Well, you can do this with COVID long haulers. You can do it with COVID vaccine reaction. You can do it even with acute COVID if you want it, but more for these chronic syndromes. The problem is it used to be a reimbursed therapy, or I should say a procedure, SPECT brain imaging. Now it's very limited. Most of the time it's out of pocket. At our hospital, the cash price is $2,500 per scan. And it gives me, unfortunately, information just on that one dose. If I want to look at another dose, suppose the second scan doesn't look so good, it's another treatment at a different dose and another brain scan after each different dose. Well, the other thing is that this scan was done about 3 hours after people came out of the chamber. It was the delayed effect of what happened in the chamber. You could never see what was going on with the brain while you're in the chamber until now. And what I've done is adapt EEG, and EEGs have been done in the chambers for years, looking for oxygen toxicity, many, many years ago, and seizure disorders and so on. But this is a standard EEG, but a wireless headset. And I'm in the chamber here. And what I do is take people through a dosing profile, and I watch the brain live. And these are the different frequencies: delta, theta, alpha, low beta, beta, high beta, gamma of electrical current in the brain. We're looking down on the top of the brain here, and these colors are according to standard deviations from a normative database. And what you can see is this individual in the delta frequency, which is usually associated with injury and is the dominant frequency during sleep. We don't want to be asleep when we're awake, and showing it through all the different lobes. They're anywhere from 3.5 to 4.2 standard deviations too much of this. Here we have a more normal amount of the different frequencies. And this is the three-dimensional imaging of that, looking at connectivity and looking at the surface, again, with standard deviations compared to normal. And what I do now is watch the brain live to look for changes in this to a more balanced and normal appearing brain. And then the entire recording gets, for each dose that I look at this at, gets quantified, and we can look and try to pick the one as a starting point of where to begin with dosing. So again, my recommendation is that start with a low dose. If you can't, if you can't take advantage of other techniques and you're just doing this empirically, start with compressed air and do a cluster of treatments and look for symptomatic improvement, which is the most sensitive way. It beats the QEEG, it beats, SPECT brain imaging or anything. But symptomatically, to follow people is the most sensitive thing in terms of treatment. In dosing, I think the QEEG may help more. So if I sum all of this up, hyperbaric oxygen is a dual component drug composed of increased pressure and increased pressure of breathing gases, predominantly oxygen. It has effects on gene expression and suppression in normal cells and in disease pathophysiology. And those effects are dependent on the different pressures and oxygen levels that you give to the patient at the time that you intervene in their condition. So the pathology changes from the time of acute infection as you go on. Number 3, Hyperbarics has primary effects on inflammation and the immune dysregulation. Hyperbarics is showing benefit in acute COVID, in long haulers, and possibly even in vaccine injury. The experience of this, though, in the vaccine injury is just limited to my one case in my little world. I don't know of anything beyond that. There's nothing published that I've seen. Dosing of this, though, is uncertain, at least the exact dose of it. But it appears, at least in acute COVID, there's a broad range of responsiveness, and maybe in long haulers disease as well. And thank you.
Thank you so much. That was really awesome. Are there any questions out here from our attendees? If you do, raise your hand or put them in the chat. And Dr. Harch, if you can do this share. Yeah.
I'm trying to punch the chat and it's not. Oh, there it is. Okay. And okay.
So it's a end share or stop sharing somewhere. In the
Oh,
meantime, Kanji.
Stop sharing.
Yes.
Here we go. All right.
Okay, perfect. So Kanji, there's a hand raised and now I don't see it anymore. So I don't know.
Yeah. So this is the second time I've heard you speak a little bit, Dr. Harch. And so I've been following up and reading. And one of the things that I don't have access to, or we don't have access to a lot in Canada, is a lot of HBOT machines or chambers and stuff, so forth.
Yes.
So I saw that some people are talking about exercise with oxygen. And I guess this was promoted by a German fellow by the name of Van Arden, I think was his name.
Yes, Van Arden. He's written Van Arden, yes, DENNE. He's written a book on it.
So do you have any experience with this? Is this useful in any of these cases, or is it not?
Very likely. I think that it may. I've got Van Arden's book and I've really dug into it because there's a lot of similarities in what he's done and what he's showing and what we've been able to do with hyperbaric oxygen. The exercise with oxygen EWOT is a very real therapy. And I just don't know that it's been applied to anybody with vaccine injury or long hauler. So in the absence of chambers, and the problem is portable chambers have now been outlawed for sale in Canada.
Yes.
As I understand it. I can't believe how reactionary it's gotten, but you're in a tough spot up there. And in lieu of it, yes, I would, I'd give EWOT a try.
Okay, thank you.
I don't know, all the chat things disappeared. There were 4 of them on there, but I
think Joel's going to help me out with that.
Yeah, I can't pull them up.
My dogs are
unshared.
Yeah, just got home.
I can help you a little bit. Just going over a couple of questions. Are there any contraindications? What if someone has seizures and is on medications for seizure disorder?
That's a tricky one. Okay, it really, you will see in all of hyperbaric medicine untreated pneumothorax, meaning a collapsed lung, not an internal collapse from atelectasis, but air between the chest wall and lung. That's called a pneumothorax. And I'm sorry, I don't mean to insult you if you're a doctor, but you probably know that. The point is that everybody says, oh, that's an absolute contraindication. Okay, yeah, that's true. But nobody gets in a chamber with a pneumothorax. So the reality is that you have to just be a little more careful with certain things. Active wheezing can be a problem. And so we've accommodated that by trying to do all the bronchodilators, everything else. And if people are wheezing, we don't put them in. But if you have to, you can slow your compression and decompression to try to, minimize risk. It's all about risk and risk acceptance. Seizure disorders, you will see, is one of the biggest or most ballyhooed complications of hyperbaric oxygen. So every human being has a sensitivity to increased oxygen. So if I put you in a chamber right now, take you to 3 atmospheres and leave you on pure O2, between roughly 2.5 and 3 hours, you have an oxygen toxicity seizure. People with neurological disease are more sensitive. People with seizure disorders even more sensitive to oxygen. However, in a certain range, this is therapeutic for seizures. and I use it to actively treat seizure disorders. So what I tell you is, if you have a seizure disorder, you go be treated by somebody who knows hyperbaric medicine and a doctor. And I would try to stay in the low treatment range and have the treatments be shorter. And you watch, usually, unless you're at a high dose for a long period of time with each treatment, where suddenly people will erupt with an oxygen toxicity seizure. It's a kindling effect with repetitive exposure to the oxygen. They will start showing either increasing lethargy and fatigue, or 40 different signs and symptoms, most of them having to do with some upregulation of the nervous system, twitching, tremor, jerking, paresthesias, dizziness, nausea, vomiting, visual symptoms, etc. And those come on before usually you see an overt seizure. And you have to be watching for them and talking to the patient. So those are main things you need to watch for.
There's another question. Is mast cell activation syndrome a contraindication to hyperbaric oxygen treatment? Many of the vaccine injured have MCAS and some don't tolerate hyperbaric well.
Don't know the answer to that. And we don't know why they're not tolerating it. This can be a dose issue. I just treated a patient today, a young man with a very unusual autoimmune syndrome in response to insect envenomation. And he ended up with a chronic neurological problem, got hyperbaric treatment, and they treated him at what seemed like an innocuous level. He got progressive oxygen toxicity symptoms and finally couldn't go in the chamber anymore. I wasn't certain how much they gave him, and today we tested him. And when we got to an oxygen level of 1.3 atmospheres of O2, he started having bizarre symptoms and sensitivity. So, I don't know if these people who claim with COVID-19 vaccine reaction who got hyperbaric oxygen, if in fact they're being overdosed and given those high doses that some people have published, or whether they've been given a low dose regimen. If it's pressure that seems to even exacerbate mast system or mast cell activation, I don't know. So I can't answer that, and that's an unknown. Again, it's a practice of medicine issue.
Marlene has a question. She asked, what if someone has tremors as part of their injury? Would that be a contraindication or just go low and slow?
No, that's a part of the injury. And you're looking to try to reverse the injury and reverse the tremor.
All right, awesome.
And I have just one comment.
Go ahead, Joel.
One comment and one question. I'm Joel Walskog from React 19. First of all, thank you for the outstanding presentation. One thing I can tell you anecdotally is we have a lot of people within React that tried hyperbaric for myocarditis. And I mean, again, this is anecdotal, but fairly immediate positive reaction in many of them. And I would assume that you'd think that's probably the anti-inflammatory effect. I
would almost bet on it.
Yeah, the other thing I was going to say is we have a care fund, which we give out grants up to $10,000 for, people that are really in financial dire straits for uncovered medical expenses and future proposed treatment. And one of them is often hyperbaric. And it's very expensive. And we spend a lot of dollars of our care fund on hyperbaric.
Yes.
It's often $10,000, and that maximizes out what we can give them. Is there any way that you can see that what's the most cost-effective strategy for people, well, say with long haulers or say VAX injury, to try to make the most cost-effective treatment regimen?
I don't have a good answer for that. The problem is most cost-effective, you could go out and buy a used or a really cheap chamber on the internet. And the problem with that is the used chambers, we had so much problem with it. I had to tell my patients, we can't do that anymore. We have to go all through the manufacturers and so on. But you get one and then you're kind of on your own. And it's a gamble that you're going to dose yourself and you will respond. That may be the most cost effective. Otherwise, you're stuck with trying to go someplace with somebody who, a healthcare professional who practices it. And the problem is it's not insurance reimbursed. You know, I'm working on this in terms of we're trying to get this disseminated, and I'm working with some groups where we're going to be able to establish multiple centers. With this diagnosis, though, I mean, you see what happened. The objection to my YouTube lecture was that I had those last few slides on vaccine injury. It's an injury that doesn't exist. It's a diagnosis that doesn't exist. So number one, getting funding for it, getting insurance reimbursement for it, this is going to be darn near impossible because you got a fantasy disease that you're dealing with purportedly. So I don't have a good solution for you to that answer right now. You know, it's going to just take more popularization of this, more demand, and more large chamber centers that are medically run, and where this can be done in a cost-effective way. Probably the most cost-effective, and there's a lot of discussion about this, is converting commercial airlines to hyperbaric chambers. You know, they are hyperbaric chambers. They're all tested to roughly a 2-atmosphere limit, which you can, you know, achieve and do a lot of what I've shown you here in, you know, pull one up to a hospital and turn it into an ICU. But we can't do that yet. And, you know, if we could mobilize that graveyard, everybody who's flown over the Western United States, you've flown over the desert area out there, and I think it's Nevada or Arizona. That's the, you know, parking place for all of the decommissioned airlines. There are hundreds of them.
Sure.
Hundreds of hyperbaric chambers there.
Well, thank you.
Okay, there was one final question or comment. This is from Stan Lang. Strategy of purposeful hyperventilation called the Wim Hof method. There are claims that this will elevate the FiO2 above 100%. I imagine this would affect airway pressure like CPAP, which might affect FiO2. Would you speculate that self-induced increase in airway pressure would have a similar effect to hyperbaric? While more subtle, it's free and can be done at home.
It might, but when you hyperventilate, the other thing you do is drop your CO2. And CO2 has about 10 times the effect on vascular reactivity that oxygen does. So a few millimeters change and this is in fact why hyperventilation was stopped as a mechanism for controlling cerebral edema in acute cerebral trauma, acute head trauma, is that as you blow the CO2 down, you vasoconstrict arteries in the brain dramatically. Yeah, you drop the pressure, but you also decrease oxygen delivery. And in fact, it was more harmful. So you know, I can't give you a good guideline for doing that, but a similar type of thing is done with masking, but in kind of the opposite direction. And what they do is the Institutes for Achievement of Human Potential in Philadelphia, or outside Philadelphia, has used this for treatment of all of their brain injured children. And what they do is they have the children, it's effectively like breathing into a paper bag for a hyperventilator, but you breathe in for a period of time. Essentially, you're rebreathing your exhaled oxygen. So oxygen level drops, which vasodilates arteries in the brain, and your CO2 level rises, which powerfully vasodilates. And then they take the mask off, and in the next few breaths where you return and oxygenate your blood normally, you take advantage of that gap of time where the blood vessels in the brain are still dilated to deliver more oxygen to the brain. And their claim is that it works. They've been using it for, I want to say 40 years or more. But it's kind of what you're trying to do with Wim Hof, but in a different way, you know, trying to force more in there by pressure. The other thing I would say is that he didn't specify with his question, but this was also a question about changing your breathing while in a hyperbaric chamber. And people think, oh, if I breathe faster, I may get more in. And no, again, you vasoconstrict, and that CO2 is more powerful than the oxygen. Other people have tried to hold their breath in the chamber, and you can do that. But what that ends up doing, again, dilating the brain, now you're getting more oxygen there, and you don't control how much you get. And this was done years ago with what's called Carbogen, when they did hyperbaric treatments with 5% CO2 and 95% O2. And what they found is the onset to seizures went like this. It was very, very fast. So don't mess with your breathing in a chamber. You just breathe, and relax. And yeah, you could try masking even. And I don't know about the Wim Hof to really give direction there.
Very, very interesting. I think we're going to call it a wrap unless there are any other questions. Sorry, there might be some dog noise going on in the back. And there is. So if there are not any more questions out there, I'm going to call it a wrap. So this kind of segues into what we're going to do on our next call on November 1st. EECP, Enhanced External Counterpulsation. If you guys haven't heard of it, please look it up, because I think this is kind of complementary to HBOT, it seems like. So Mo Solati is going to be our speaker, and he's not a physician, but he runs this EECP center, and it helps to induce collateral vessels in CAD, coronary artery disease, and it's used for end-stage cardiomyopathy. Once you've had all your cabbages and all your good stuff, and you've got a big, baggy, floppy heart, they do use it to help revascularize, and it also stimulates nitric oxide production. So I thought it was pretty interesting, and I spoke to this guy a couple of months ago, and we're going to get him on a call next week, and I think it's going to be pretty interesting. So if you guys are able to do that, that's going to be November 1st at 7 p.m. Same bat time, same bat channel. So it was a pleasure. I do appreciate your time, Dr. Harch. And for those of you who didn't meet Dr. Harch at the conference this past weekend, they are the dynamic duo, 100%. They're the cutest damn couple that's ever been. And of course, that's because Dan and his wife weren't there. But Dan was there, but his wife wasn't. So you guys, you rock it. And please give love to Juliet.
I will.
And thank you. And God bless you all. We'll see you next time. And I do appreciate everyone's time. Take care.
Have a good night.
Good night.
Thanks so much. Great work.
All right. Thank you.